SLE. What is the definition? It's a chronic multi-system disorder, frequently involves skin and joints, and characterized by the presence of anti-nuclear antibodies. Differential diagnosis? We got rheumatoid arthritis, antiphospholipid syndrome, systemic sclerosis, mixed connective tissue disease, Lyme disease, HIV, CMV, infectious mononucleosis, glomerulonephritis, chronic fatigue syndrome, generalized tonic-clonic seizures, fibromyalgia, depression, and septic arthritis. Epidemiology? Mostly between people that are 15 to 45 years old, it is 12 times more common in females. In the UK, the prevalence is estimated at 28 per 100,000, and it's more likely in people with African descent. The etiology is not really well known, but it could be possibly due to the complement deficiency, polymorphisms of integrin alpha-M interferon regulatory factors. Environmental factors can be drugs like procainamide and isoniazid, phenytoin, and so on. And infections, possibly EBV. Clinical features. So, clinical features, you have mellow rash, which is a butterfly rash, where you have erythema over the cheeks and the nose, but it spares the nasolabial folds, and then it's usually photosensitive, so it can be painful. You can get discoid rashes, which are like usually circular, which are erythematous raised patches, keratotic scaling and follicular plugging can happen. You can also get fatigue, and then a lot of other symptoms as well. Clinical features like weight loss, fever, oral ulcers, alopecia, arthralgia, arthritis, fibromyalgia, Raynaud's phenomenon, chest pain, shortness of breath, hypertension, nephrosis, and lymphadenopathy. For the pathophysiology, there is high affinity of IgG antibodies to the double-stranded DNA and nuclear proteins. Usually there's less central tolerance and clearance of apoptotic cells are impaired. So, what is the investigations, management, and the prognosis? Investigations, so you do FBC, activated prothrombin time, E's and E's, you check for these antibody markers, autoimmune markers, urinalysis, the Coombs test, you do a chest x-ray, check complement levels, do a skin and renal biopsy, check the exudate and pleural aspiration, and many, many more. And management, so conservative, you need to do like diet advice, stop smoking, sun protection is really key, and exercise, eye drops for dry eyes, good oral care to help the ulcers, and prevention of them, and artificial saliva. Medical would be NSAIDs. If that doesn't work, then hydrochloroquine. That usually takes a while. Corticosteroids can be used next. Methotrexate and folinic acid can be used on top of corticosteroids. Other options are cyclophosphamide, azathioprine. I'm sorry if I'm pronouncing these wrong, I'm not very good at reading. Mycophenolate and plasmapheresis. And then prognosis. 5-year survival rate, 95%. 10-year, 92%. Early mortality is usually due to active diseases like renal, CNS, thrombosis, and infection. And later mortality is usually due to infection or premature atherosclerotic vascular disease.